floors 4 through 7 are what we call the hospitality component of our hospital, which is where the patient rooms are located. The rooms are divided into two types. They're intensive care units and they're what we call acute care units, or more standard hospital rooms. All of the rooms are private, and the intensive care units are very, very similar to the acute care units. This is a change from earlier planning, even from 10 years ago. Before this time, ICUs were very, very different than acute care rooms. They had multiple beds within them, and they were more ward-like. What we're finding is that patient outcomes are better the more private facilities we provide for patients, even in the intensive care setting. It also allows us to have more family involvement in the intensive care setting. So with our private rooms, each of our intensive care units will have family rooming in so that the patient's family can spend the night. We're also providing bathrooms in our ICUs, which is a new feature for many ICUs. But we find that even many of our patients now, being monitored or otherwise, if they can get up, we like them to get up. And frankly, if the family member is sleeping in the room, they prefer having a bathroom within the room. So that has allowed us in the planning to say that the intensive care units, which exist on the 4th floor, are basically the same plan as the rooms on the upper floor for acute care rooms. This is important because we need to have the flexibility of the number of ICU beds we have versus the number of acute care beds. In an older model, if we need more intensive care beds, we have to find a place to, in an existing building, to gut a whole floor and build intensive care units on that floor. In the setting we have now, we can convert our acute care units into intensive care units without demolishing anything. The rooms are very, very similar in their basic organization. So again, providing flexibility. Why is this important? In the last few years, we have seen increasing levels of numbers of ICU beds around the country, especially here at Stanford, as our patients are very, very high acuity patients. But now, as we've talked about the interventional platform, where many surgeries are now being done in less invasive ways, the utilization of post-surgical ICU beds is actually going down. So rather than a heart patient being in the ICU for 4 or 5 days, they're there overnight, we may need less ICU beds. So when we started the planning of the hospital, we were planning to go from our current number of ICU beds, 66, to 140 beds initially. Early on in the planning, we took that number down to 120. Now we're building 104. So having that flexibility makes a big difference in the usability of those beds within the hospital. We don't want to have intensive care beds that can't be used if we don't have patients at that level of acuity. Levels 5, 6, and 7 are our standard nursing units. The organization of these units are very different than where planning was a few years back. So if you look at the existing hospital units, these units are triangular. The thought process for that was the triangle as a geometric form has the most perimeter for the least amount of space inside. And this was felt to be a very, very good diagram for a hospital because we wanted to get as many patient rooms in a unit, which is the perimeter, for the least amount of space. Sounded like a very, very logical plan, and many hospitals are still being planned this way. What we found here at Stanford is that organization did not give us enough space in the center of the unit to support our nursing requirements, our medical education requirements, etc. So yes, the unit was smaller, but it didn't have everything in it we needed to support our patients. So we went to a completely different model. We said geometrically, what shape can give us the most center, the most core, for the amount of perimeter we had? So we went to square units. those square units provide us with the ability to more than double the amount of nursing space we have on each floor, provide conferencing space for our physicians in training, our other groups that need to have conferencing services such as social service, nutrition, other groups in the hospital. So we now have enough space to actually support the number of patients within the nursing unit. The other thing it does is give us enough core so that all of the materials coming up and down the building happens within the core of each of those nursing units and then distributes out to the patients on the perimeter. Again, this provides us the ability for the public to have their own corridors into the unit facing the patient rooms, and all the access of materials coming in or patients being moved to various areas of the building happening within each of the 4 cores, completely separating the public side from the service side of the building, or as we say, from off stage and on stage. The rooms themselves are, as we said, all private. All of the rooms provide family rooming in, including intensive care and acute care. And probably the biggest single feature that will differentiate our hospital is that the patient rooms themselves, because of the organization of the room, have enormous windows with views out to nature. This is important for several reasons. One, we do planning in a way as it's called evidence-based design, meaning we study the patient environment in a scientific manner and see what impacts the patient experience from a facility standpoint. And one of the key things we found is views of nature from patients decreases the length of time patients spend in the hospital. They need less pain medication. They go home sooner. They feel better in the hospital. We don't know exactly why this is. We're finding more and more about it in recent neurologic research. But it's a very important and statistically repeatable factor in hospital care. So we wanted to not only follow that piece of scientific evidence, but we wanted to expand it as much as we could. So we've not only provided views out of all of our windows, we've provided enormous views out of all of our windows. So each patient room has a window that is 7 feet tall by 13 feet wide. And because of our taller hospital, our pavilions, our hospitality area being higher than any of the other buildings in the region, we have incredible long-distance views from each of our hospital beds. So we believe we are going to provide the ultimate environment for patient care in these units as they're going to be built. How can we do this economically? Because windows are expensive. We get a lot of heat gain from the windows, especially here in California. That has all been dealt with the engineering of the windows themselves. They are controlled by solar panels. They have elements between the 2 panes of glass that lower the amount of light that comes into the building. So we're able to get the advantage of as much view as possible with minimizing the amount of heat gain from that amount of light. So again, taking the current technology that's being developed basically here in Silicon Valley and utilizing that within the planning of the hospital.